Orthodontic headgear is a type of orthodontic appliance attached to the patient's head with a neck strap or a number of straps around the patient's head. The device typically transfers the force to the teeth via a facebow or JHooks to the patient's dental braces or a palatal expander that aids in correcting more severe bite problems or is used in retention of the teeth and jaws of the patient. Need for treatment and concurrent corrections. Headgear is most commonly used to correct antero-posterior discrepancies. The headgear attaches to the braces via metal hooks or a facebow. Straps or a head cap anchor the headgear to the back of the head or neck. In some situations, both are used. Elastic bands are used to apply pressure to the bow or hooks. Its purpose is to slow or stop the upper jaw from growing, thereby preventing or correcting an overjet. Other forms of headgear treat reverse overjets, in which the top jaw is not forward enough. It is similar to a face mask, also attached to braces, and encourages forward growth of the upper jaw. Headgear can also be used to make more space for teeth to come in. In this instance, the headgear is attached to the molars, via molar headgear bands and tubes, and helps to draw these molars backwards in the mouth, opening up space for the front teeth to be moved back using braces and bands. Multiple appliances and accessories are typically used along with the headgear, such as power chains, coil springs, twin blocks, plates or retainers, face masks, a headgear helmet. A headgear helmet is a cervical headgear with a cap that covers the entire head, lip bumpers, palate expanders, elastics, bionators, Herbst appliances, Wilson appliances, other headgear, hybrid twin blocks, positioner retainers, and Jasper jumpers. Many patients wear a combination of, or all of these appliances at any given time in their treatment. Forms of headgear treatment. Headgear needs to be worn between 12–22 hours each day to be effective in correcting the overbite, typically for 12 to 18 months depending on the severity of the overbite, how much it is worn and what growth stage the patient is in. Typically, however, the prescribed daily wear time will be between 14 and 16 hours a day. Orthodontic headgear will usually consist of three major components. Facebow. First, the facebow, or JHooks, is fitted with a metal arch onto headgear tubes attached to the rear upper and lower molars. This facebow then extends out of the mouth and around the patient's face. JHooks are different in that they hook into the patient's mouth and attach directly to the brace. See photo for example of JHooks. Head cap. The second component is the head cap, which typically consists of one or a number of straps fitting around the patient's head. This is attached with elastic bands or springs to the facebow. Additional straps and attachments are used to ensure comfort and safety. See photo. Attachment. The third and final component, typically consisting of rubber bands, elastics, or springs, joins the facebow or JHooks and the head cap together, providing the force to move the upper teeth, jaw backwards. Soreness of teeth when chewing or when the teeth touch is typical. Patients usually feel the soreness 2 to 3 hours later, but younger patients tend to react sooner, e.g., 1 to 1–2 hours. The headgear application is one of the most useful appliances available to the orthodontist when looking to correct a Class II malocclusion. Face mask and ReversePull headgear. Face mask or ReversePull headgear is an orthodontic appliance typically used in growing patients to correct underbites, technically termed Class III orthodontic problems, by pulling forward and assisting the growth of the upper jaw, maxilla, allowing it to catch up to the size of the lower jaw, mandible. Face masks or ReversePull headgear needs to be worn between 12 and 22 hours per day, but typically 14 to 16 hours a day is effective in correcting the underbite. Overall wear time is usually anywhere from 12 to 18 months depending on the severity of the bite and how much a patient's jaws and bones are growing over this time. The appliance normally consists of a frame or a center bars that are strapped to the patient's head during a fitting appointment. The frame has a section which is positioned in front of the patient's mouth, which allows for the attachment of elastic or rubber bands directly into the mouth area. These elastics are then hooked onto the patient's braces, brackets and bands, or appliance fitted in his or her mouth. This creates a forward pulling force to pull the upper jaw forward. The orthodontic face mask typically consists of three major components. Face frame. First, the face frame is a metal and plastic structure which is adjusted to fit onto the patient's face. The frame is normally stabilized on the child's face with the aid of a chin cup and a forehead pad. These are padded to ensure patient comfort. The frame typically has a horizontal bar or mouth yoke, which the orthodontist will adjust so it is correctly positioned in front of the patient's mouth to get the elastics to apply the force in the desired direction. The mouth yoke has a number of hooks, 4 to 6 depending on type of appliance, see photo with 6 hooks, which allows the orthodontist to attach elastics or springs directly from the face mask into the patient's mouth. The frame allows the patient to move his or her head freely and to talk. All other oral activities are typically limited or restricted, such as eating or playing sports or playing a wind musical instruments, although drinking is recommended using a straw so as not to remove the whole appliance at night or in the day when thirsty. Head cap. Some face masks and all ReversePull headgear have a second part which consists of a head cap, and is made up of a number of straps fitting around the patient's head. In this case the head cap is used to stabilize the face frame described above and to ensure it is held correctly in position. See photo example of ReversePull headgear with head strap/cap. Attachment. The third and final component is the mouth attachment, typically using rubber bands joins the face mask from the mouth yoke into the patient's mouth. The elastics hook on the patient's braces or other such suitable oral appliance. As the elastics are flexible, up to 6 elastics may be used to provide various forward and sideways forces on the patient's teeth and arch, while still allowing the patient to open and close his or her jaw. In some cases surgery is required in conjunction with a face mask or ReversePull headgear. Many parents and doctors recommend using early intervention, ages 7 to 13, by using a face mask to avoid costly and painful surgical procedures later. The appliance is very effective in correcting Class 3 orthodontic problems in younger or adolescent patients that are still growing. Initially, it can be difficult for children to wear a mask or headgear, however most doctors and parents agree that children and adolescents adapt quickly to such changes and requirements. Parents should be aware that their child is often better off wearing a face mask or headgear to avoid later surgery, and the patient, friends, and school peers normally get used to the new appliance after just a few weeks of wear. DeLayer ReversePull Face Mask. The overall treatment of skeletal Class 3 malocclusion is still regarded as a significant problem facing the orthodontic profession today. The Class 3 malocclusion can be caused by a retrognathic maxilla, a prognathic mandible, or a combination of both. Sometimes surgical correction after the completion of growth phase is unavoidable in many cases, but most orthodontists will proceed with prescribing one of a number of different types or designed of ReversePull headgear or face mask. Typically most patients with such maxillary deficiency, underbite, the use of a face mask for protraction of the jaw and maxilla is one of the most common treatment plans used. The Jean DeLayer ReversePull Face Mask was introduced by DeLayer in 1971. The DeLayer face mask is unique in that it requires no additional head cap or straps to hold the appliance to the patient's head, and it uses the direct force of the elastic bands into the child's mouth, attached to the braces using an intraoral hook or a functional appliance, such as the Rapid Palatal Expander, RPE, to hold the mask or face frame in place. The photo is of an orthodontic extraoral appliance commonly known as a face mask or a ReversePull headgear. This specific design is a DeLayer type face mask and is fitted to the patient's face, between 14 and 16 hours a day, during this treatment phase. The mask attaches to the patient's upper jaw, typically, with braces fitted, using elastic bands, shown. This pulls the upper jaw forward while it is growing to correct a class 3 malocclusion. The elastics also effectively hold the mask in place, on the patient's face. The delayer face mask is also unique in that it does not obstruct the child's vision or line of sight, or hinder glasses wear, as the frame wraps around the sides of the patient's face. This benefits daytime, evening wearing of the device. The drawback is that it somewhat limits the patient to lying on his or her back when sleeping, as the frame on the side of the face caused by pressure from the patient's pillow. The treatment of class 3 problem malocclusion is considered very effective when the patient is still at the age when bone developmental is prevalent, ages 7 up to 13. This is considered the optimal time for the orthodontist to prescribe and fit such a face mask. Typically then the treatment should start in the early mixed dentition phase if mandible growth is still continuing and will typically be worn for 12 to 18 months depending on the prescribed treatment plan. The second photo shows detail of the reverse side of an orthodontic extraoral appliance commonly known as a face mask or a ReversePull headgear. This specific designed a layer type face mask and is fitted to the patient's face. The padding that fits to the child's forehead and chin is shown. The appliance is typically worn for between 14 and 16 hours a day during this treatment phase. The mask attaches to the patient's upper jaw, typically, with braces fitted, using elastic bands, shown. This pulls the upper jaw forward while it is growing to correct a class 3 malocclusion. The elastics also effectively hold the mask in place, on the patient's face. Using a face mask for class 3 correction is however also known to cause problems as the forces due to maxillary protraction are normally applied to the upper jaw's teeth. This can cause some level movement of the upper teeth causing crowding. This can be mitigated by using various functional appliances to reduce the orthopedic treatment impact. The patient is required to become accustomed to wearing the appliance for relatively long periods of time, although it has been shown that with regular wear, after a few days to a week most patients become accustomed to the face mask. JHook headgear. The treatment of a class 2 malocclusion can require the specific inclusion of a JHook headgear to the treatment plan, needing the patient's canine teeth retracted. A common approach for canine retraction is the use of headgear with JHooks. Since this approach incorporates extraoral anchorage, using a head cap or straps over the patient's head, it is considered most effective in maximum anchorage cases. This treatment plan will require the patient to have a head cap strapped and fitted to his or her head. Then the plan requires having metal hook inserted into the patient's mouth, typically hooking onto the patient's braces with a designed end hook and slash or elastics. The opposite end of the hook is attached to the head cap through a safety tube, with elastics as shown in the photos. Sometimes multiple J-hooks, 2 upper and 2 lower, will be used attaching to both the upper and lower canine teeth or used in combination with a facebow appliance headgear. The photo is of an orthodontic J-hook appliance headgear. This specific design requires the head cap straps to be sized and fitted onto the patient's head. The patient then wears the device strapped to his or her head. The orthodontist will have J-hooks inserted into the patient's mouth, left and right, between 14 and 16 hours a day, during this treatment phase. Headgear J with J-hooks attaches to the patient's upper jaw, typically, with braces fitted, using elastic bands, shown. This can hold or pull the upper canine teeth and jaw backwards while the jaw is growing to correct a Class 2 case. Orthodontic helmet appliances. The orthodontic profession has constantly struggled with the improvement of anchorage of both inter- and intraoral appliances. In some treatment plans, the use of a full head cap or orthodontic helmet device was recommended. The advantages of this application is that the anchorage of the intraoral facebows, in this case the patient has both an upper and lower facebow fitted, is significantly improved using such cap or helmet. Other appliances and devices, such as a full rigid helmet headgear, have been designed and patented to fit onto the patient's head and provide a stable platform from which the orthodontist can attach various elastic bands, springs, metal face bows directly into the patient's mouth. According to the inventor Frank O. Nelson, 1967, the helmet headgear of this type solves this long-standing problem of applying anterior or forwardly pulling forces to teeth, and is ideally adapted to correction of a variety of malocclusion forms. The helmet headgear is useful to reposition individual teeth or groups of several teeth which show, for example, over-retraction and distortion, tilting of the tooth axis from its normal orientation, after closing a natural or post-extraction gap in the dental arch. The helmet headgear is equally useful in correcting inter-arch relationships where all the teeth in one arch must be shifted with respect to the other arch. The type is also sufficiently flexible that it may be used for simultaneous application of anterior forces to one group of teeth, and posterior forces to another group of teeth. Summary: the orthodontic headgear of this type comprises a substantially rigid helmet adapted to fit on a patient's head. The helmet includes a crown portion, and a pair of side portions depend from the crown portion and are formed to fit against the sides of the head. A rear portion of the helmet depends from the crown and is formed to fit against the back of the head. A front portion of the helmet depends from the crown and is formed to fit against the patient's forehead. A member is attached to and extends forwardly from the helmet, the member having a forward portion spaced from and positioned ahead of the patient's mouth when the helmet is on the head. Fastening means are provided on the forward portion of the member, and are adapted for attachment to an orthodontic appliance. The helmet is typically tightly held in position on patient's head using a chin strap with chin cup and other straps around the base of the patient's head. These helmet headgear appliances were experimented on in the 1970s and successfully prescribed to a number of patients at the time, but generally are only used in specific cases today. Adverse effects. Researchers have studied the long-term effects of orthodontic headgear have found that it may flatten the face and prevent the chin from coming forward, pushing both the upper and lower jaw down and back, into the airway. In more technical terms, it inhibits the natural growth of the jaws and lead to a reduction in the SNA and ANB angles, which relate to the forward position of the maxilla and the mandible, and good indicators of the size of a person's airway. Reductions in the width of the airway, potentially causing obstructive sleep apnea, OSA, may also result from headgear. In some cases, eye injuries have been reported, which is minimized with the use of safety release straps and safety face bows. Teenagers prescribed orthodontic headgear often face social stigma and bullying due to their detracting appearance. The need for headgear in orthodontics and its application by practitioners has somewhat decreased in recent years as some orthodontists use temporary implants, i.e., temporary anchorage devices, inside the patient's mouth to perform the same tooth movements. However, the headgear is still widely used and a very effective appliance used by orthodontists today. Soreness of teeth when chewing, or when the teeth touch, is typical. Adults usually feel the soreness 12 to 24 hours later, but younger patients tend to react sooner, e.g., 2 to 6 hours. Adults are sometimes prescribed headgear, but this is less frequent. The headgear is one of the most useful appliances available to the orthodontist, but many patients find it difficult to comply with daytime wear, so it is mainly worn in the evenings and when sleeping. A similar appliance is the ReversePull headgear or orthodontic face mask, which pulls the patient's teeth forward, rather than back, as in this case.
Please subscribe and thanks for watching.